Professor Mick Cooper, thank you for welcoming us here. We just wanted to have a talk about CBT and the situation with CBT in the UK at the moment. Just to start, what do you think of CBT as a discipline? What's your experience of it?
I mean, I think CBT can be enormously helpful for people. I've been through CBT myself a few times, and sometimes it's been great. Sometimes it hasn't been so great, but I mean, I think it's clear from the research evidence that for some people it can be enormously helpful and very, very valuable. I think the problem that a number of us are raising really is the danger that we get into this kind of therapeutic monoculture where CBT really becomes the only thing on offer to people. I think a lot of us would feel CBT is great, but for some people it just doesn't work, or for some people it's not helpful. So having a health service where CBT becomes the main thing on offer, I guess, is something that some of us are worried about.
Why do you think that there is such a drive for CBT to be the therapy of choice? What would be the motivation?
Well, I think the CBT have done some great research, and what they've done is they've actually gone out and they've researched their approach, and they've shown that it's helpful, and they've shown that people do get better on average using CBT. And the government, understandably, is going to the evidence base and saying, well, what do we know that works? And what they're seeing is that when they look at that, they see that CBT works. One of the problems with that, though, is that it depends on how you read the evidence. So if you just use a very kind of strict definition of randomised trials, then that shows that that gives you a lot of evidence for CBT, but that doesn't take into account loads and loads of other kinds of ways of looking at the research, and is based on the assumption that randomised trials are the one true source of evidence fact, and I think a lot of us would say they're much more problematic than that.
So what other ways are there of looking at?
Well, for instance, you can look at when clients have good outcomes, what are the things that relate to those good outcomes, and when you look at that, what you find is that a strong therapeutic relationship is probably the most important predictor of positive outcomes. You can see that clients being motivated and involved and being caring about the work and choosing the work that they go into is also really important. If you look at evidence if you look at just what outcomes are generally across different client groups with different kinds of therapists, you find that clients seem to do just as well, whatever the different kind of therapy. And what seems to make sense is that all these different kinds of evidence should be included when the government are drawing up guidelines, not just one narrow form of studies. Problems with RCTs, these randomised trials, is basically that most of them are done by the proponents of a particular approach. So if you have somebody who's a CBT therapist and who's developed their own CBT and has spent years of their life doing that CBT, and then they study CBT, it's not particularly surprising if they show that form of CBT is effective, because often the practitioners and the people who are involved in it will often have an allegiance commitment to CBT, and they may not deliberately try and show that that's effective, but understandably, that's likely to come through. And if you have a situation, say, where those CBT practitioners are also delivering what they call counselling, which they maybe don't believe in and don't think is going to be helpful, it wouldn't surprise anybody if the CBT turns out to be more helpful than when they're supposed to be doing counselling. I mean, that's fine in terms of showing that form of CBT. People who believe in CBT do better in CBT than if they do something that they don't believe in. That's what the research shows. But to take that as evidence, as hard and fast evidence that particular form of CBT is not just an effective approach, but to assume that that's the only effective approach, I think is problematic.
I mean, what a lot of people are saying is that the evidence base for other therapies is lacking. Historically, why is that?
Yeah, I mean, that's absolutely true. I mean, again, it depends what evidence base you're looking at. So if you're looking at, part of the reason people say that it's lacking is because where it's lacking is particularly in these randomised trials. So people over the years have done a lot of studies looking at whether clients in person-centred therapy, whether empathy relates to outcomes. In psychodynamic therapy, the value of interpretations, I mean, that's been looked at quite extensively. But what people in a number of other fields haven't done is that they haven't done these randomised trials which is what the government and NICE at the moment seem to be considering as the only line or the most important line of evidence. Part of the reason of that is because if you do a randomised trial, half of the people you give the therapy to, but it means you have half the people you don't give therapy to. So you have to get people say, would you like to take part in a study? And there's a 50% chance that you'll get therapy, a 50% chance you won't. And I think a lot of people, particularly in the say the person-centred field, are just horrified at the thought of saying, well, you know, you may not get therapy. So people have tended to shy, and it's a real ethical problem about how we do that. And that's part of the reason we haven't done trials. Also, in some of the more humanistic and person-centred approaches, people have kind of thought, well, you know, we don't really like research and we're not interested in research, and haven't actually taken that forward. So I think it's partly our own doing, in a sense, people in that field, that we haven't got engaged in research.
I mean, what I'm seeing here is trying to maybe apply scientific models to a discipline which isn't actually hard and fast scientific. And I think what you've just highlighted there, the fact that you can't take half the people and half of them get a sugar pill and the other get the real medication, because you can't have someone sitting there with a therapist who's not doing therapy. Is that what you're
Yeah, I mean, the guidelines for counselling and psychotherapy and what treatments get considered valid is the same as you're using for all other medical treatment. You know, NICE is not just for the psychological therapies, it's for the, you know, it's for pharmacology and lots of other treatments. So you're using the same criteria that you would use for a pill. So therefore the methodologies that are seen as valid are the same ones that would be for drugs, which is that you give half the people the drug and you don't give half the people the other drug. And that may be fine for drugs, although we've seen that even that's problematic. But I think to do that for psychological therapies, one of the important things, I mean, one of the key things about a trial is that it needs to be blind. You know, that the researcher shouldn't know what the participant is getting, and the participant shouldn't know what they're getting. You can't do that in psychological therapies. You can't give somebody therapy without them knowing what kind of therapy they're getting. And the person who's giving the therapy clearly is going to know what kind of therapy the person is getting, and and their commitment or not to it is going to make a difference. Now, that doesn't make that research invalid, but I think what it means is that you can't treat that as the absolute top of the pyramid in the way that you might do with drug trials. That I think in the psychological therapies, there needs to be an appreciation of a broader range of evidence. So that studies, for instance, I mean, one study looked across 5,000, 10,000 perhaps clients and asked them and looked at whether they changed or not in real world settings. And what that study found is that psychodynamic therapy, CBT, person-centered therapy, all had about equivalent outcomes. Now that research isn't perfect in any way. I mean, there's problems. We don't know exactly what they were delivering. We don't know whether some people who dropped out maybe didn't do as well. But when you've got that evidence from, say, 5,000 to 10,000 people, and when that evidence is discarded, compared with evidence, say, from 40 people in a randomised trial, that just doesn't seem, I think, to a lot of us to make sense. I don't think any of us would argue that there's anything wrong with us. I mean, at the moment, we're trying to do a randomised trial ourselves of counselling in schools. So, it's great methodology, but to prioritise it as the only source of truth, I think a lot of us would say is a real problem.
When you say a lot of us, what is your feeling of how the counselling profession is taking this massive investment by the government in CBT?
Well, I think a lot of people in the psychodynamic field, in the humanistic field, in a whole range of other fields, non-CBT fields, are looking at it and saying, well, why are questioning that? And I think increasingly now there is a movement, I'm hearing from lots and lots of different people who are saying, this just doesn't seem to make sense. And I think critically also is about user movements. Because the message that I've heard from user movements, people who actually use these services, is what they want is choice. They don't, I mean, and again, a lot of them are very supportive of CBT and find CBT very useful, but what they want is to be able to have a range of different therapies and not to have this monoculture where the only therapy available is CBT, because it just doesn't work for some people. So I think nobody's saying, well, there's a few people who maybe say, CBT is just superficial, but I certainly wouldn't agree with that. I think CBT can be very profound, do very deep work. But the problem is when it's seen as the only therapy that is on offer, and that's the only choice people get, because it clearly doesn't work for some people.